First speaker is Dr. SHARAT BABU, a very popular ophthalmologist from Andhra Pradesh, heading the SHARAT Laser Eye Hospital and a figure to reckon in Andhra. And he is going to show us an interesting video. On to you, Dr. SHARAT.
Yeah. Thank you very much, Chitra, and for inviting me to be a part of this session. And this is one case which recently I operated. And the name of the patient is Krishnaya, 58 years old. And the patient has got a cervical spondylitis. At the end of the surgery, even I have got some doubts about this, how to proceed with some other things and all. The question is, when the patient has come to me, he has got, he came with two requests. One is he wants a catalyst to be done for him, and he wants a multifocal IOL to be done, which both of them I rejected. And the reason is because I'm not sure how I can do a scan. So for this patient, I have done the thanks to IOL Master 700, where I could take the readings continuously, and then got the readings. And then, as you see, there is a astigmatism of around 0.6 or something like that. And so I went ahead and then went for a surgery. Here I took the assistance of my OT assistant, where they are holding the head, which has been continuously. There is a lot of vibrations there and all, you can see that. And then I proceeded with the surgery. Now the challenges are here one is the incision. So my incisions are always post-limbal, and so in this patient also I've done a post-limbal. And then to prevent the ballooning of the conjunctiva tenons, I just open up a little here and then went for the surgery. The second challenge is to do a clear CCC in this patient. So I put a lot of visco inside and then pushing back the anterior capsule. And usually I do with the 23G cannula, I do my side ports on both the sides. And then with the 26 needle, a capsular, I've done a capsular excision. So the challenge is, because there is a lot of movement, you want to get a nice one. And of course, you can do that with a lot of experience of doing a lot of surgeries, a lot of CCCs. But you have to be careful, like while doing the CCC. You want to get a good CCC because you want to put the IOL into the bag. Now, the second most important part is the during phaco. So because there is a lot of vibration, so what you need to do is you need to have, usually I operate under 50 or 60 intraocular pressures, but here I have gone up to 75, 80 during the phaco and even for the IA procedures. So to prevent the posterior capsule coming onto the near to the phaco probe, so pushing back, and then I could do the phaco and also the proceed with the IA also in this patient. So after that, again, while putting the IOL, see that you put a lot of visco, push back the thing, posterior capsule, and then see that the IOL is just on below the anterior capsule, and then come out and then push again. You put a lot of visco on top of that, push the IOL behind, and then do the rotation and then place the IOL in the bag. And this is under topical anesthesia, which we operated this patient. So after that, the IA and then the cleaning the methyl cellulose from the antechamber behind the IOL is normally what we do. So this is about this patient. And post-operatively, he has the same 0.75 astigmatism left at 90 degrees. And the patient is happy after the surgery. And then again, after that, again, he was asking for the multifocal and why I didn't do my catalyst for that patient. So I didn't have an answer because I'm scared, because catalyst, I'm not very sure whether I can go ahead. Probably Ramurthy and Mahipal can guide me in this aspect. And any questions are welcome. And if you need any questions are also.
Yeah, that was a wonderful video which you showed, and definitely a challenging video, but we have the answers for all the queries which you have. One, of course, before we go on to the femtosecond laser, I think even just blocking, if you do a block, the nystagmus actually gets temporarily abolished and you could do. But then this
This
amount
is
of
not
movement.
nystagmus.
So head nodding.
Head nodding only. Yeah,
Progress.
head nodding only. Yeah. So, but again, I would want to know about from the expert panel here, if we are to do on a femtosecond laser platform with the head nodding, would you go ahead and do it? I think that head nodding
I
is
don't
not
think,
a great
Chitra, I mean, what Dr. Sharat Babu advised the patient was very much correct. That
Yeah.
with that kind of a head nodding, it is a challenge to do a conventional phaco. And I don't see any reason. I mean, it's going to be very difficult to do docking, etc., with the femtosecond laser. So that was completely out. And so also was the multifocal IOL, which was Sharat Babu, I think, very rightly not put in this case. A very difficult case, was done very effortlessly.
Yeah, but he ended up having a small residual error only. So he could have very well gone in with a premium IOL. I don't see if head being held, doing a biometry should not have been such a great challenge. I would want to know from Dr. Ramurthy and Dr. Sandeep also.
I sort of agree with what you're saying. Obviously, LRCS docking, etc., would have been a problem with that amount of head nodding. And maybe if the patient was very keen, deep sedation could have been given and it could have been done, but maybe it's not worthwhile, you know. It was straightforward. He did his capsulorhexis and also well. So obviously it's more for satisfying the patient's whim. But as regards the multifocal intraocular lens, I don't see any problem. This doesn't seem to be ambly-opaque. He had good potential visual acuity. And implantation of the lens is exactly the same as a monofocal. And he had a very small cylinder only, and Sharat did it so efficiently. So I wouldn't have kept away from a multifocal if the patient asked for it.
Yeah, probably what could have been done is he could have done biometry, repeated the sort of measurement and seen whether the values are consistently the same or similar, and that would have reassured him to go ahead with a multifocal. Anaga, you want to add something? Unmute yourself.
Yes, ma'am. Even I feel the same thing, that multifocal, we could have kept it as a plan A, and then plan B in case there is an event on table, or you feel that there is a PCR or for some other reason, then we could have always put a, and then probably in this case you need to keep a 3-piece and iris claw also ready, I think, just in case there is a problem.
Yeah,
Just had a query. Dr. Sharat, was there any contraindication? Because you, other than head nodding, you get Parkinsonism patients and all people. I mean, was there any contraindication for putting the patient under deep sedation? Because that's what we do, propofol and nixolam combination. It's a 10 minutes procedure.
Oh, there is no problem at all. But then I was skeptical because if I put a multifocal, I don't know, because already he's got a lot of nodding, and I don't know how the reflections would be when he's driving. He keeps driving a scooter also. So that I didn't understand whether. So I went for a monofocal. So that's the reason. But otherwise.
What would your thoughts have been for a trifocal toric IOL in case it was needed in a particular situation? Just for a hypothetical question.
I would have gone for a toric.
Dr. Nagvekar wants.
Yes, Dr. Nagvekar.
Yeah, I just wanted to make a comment that, you know, if I achieved consistency on my keratometry in all my pre-op evaluation, and if I knew that this astigmatism is more or less fixed, I would have definitely gone in for a toric lens. Obviously, this man with all this head nodding is very uncomfortable. He would be very uncomfortable to wear glasses. I think that's the reason why he asked for a multifocal.
Yes.
And I would I would have a very low threshold for using a multifocal if the patient was so very, because I don't see how the multifocal would have caused a problem, with the head nodding, So the patient would have still been able to get good eyesight. So I would have tried to put in a multifocal, as Anaga said, maybe keep it as plan A and a backup. As regarding docking, can I just make one comment?
Yes,
I had one patient with a mild head nodding, and we managed to hold his head, and we managed to even do the femtosecond laser. If you're not as expert a surgeon as Dr. Sharat Babu, who did such a wonderful capsulorhexis, that's the most challenging thing in this whole surgery. Yes. If you have a LSCRS platform to do it for you, it would make your life much easier. So of course, I think this head nodding was very severe. So yes, definitely I would have probably not done it. But we can attempt to take this patient on the table, try to see whether holding his head, the patient can remain some steady before giving up the challenge completely.
Yeah, Dr. Merle has brought up two very important points, which we do need to keep in mind, that we need an overlay, like a Varion or a Callisto, which would make things more accurate in this particular scenario. And of course, if we are not wanting a multifocal IOL, the other options could have been IONs or VVT. And as she has mentioned in the chat, I think those are all valid points, but an amazingly well done surgery. That's what makes us discuss all this even more, that you should have left it, done it all. Thank you very much,